Well, good morning. What I'm going to talk about today is the surgical correction of the severe jaw deformity in teenagers with juvenile idiopathic arthritis. Juvenile idiopathic arthritis is a group of heterogeneous chronic arthropathies in children that begins from the age of 16 years and younger. There are 7 subtypes of juvenile idiopathic arthritis that share features similar to rheumatoid arthritis and ankylosing spondylitis in adults. So this is a typical kind of patient that we might see where the JIA affects the TMJ joints or jaw joints. It causes destruction of those joints, resulting in a severe deformity for some of these young patients. Here you see a 16-year-old young lady. Onset of her JIA was at the age of 9. Results in severe deformity of the mandible particularly. And they usually end up with significant malocclusions where their teeth do not fit together very well. And this is a what we call a cephalometric analysis. It's a side x-ray, profile x-ray of the patients that we analyze to figure out the extent of the problem and then to design our treatment protocol. So this is a typical patient with this disease process. You can see that the mandible is significantly retruded. This line right here that goes between the biting surfaces of the teeth is called the occlusal plane angle. And it's measured to this reference line up here called the Frankfurt horizontal plane. And the normal angulation there should be 8 degrees. You can see she's at 24 degrees. The other issue that these patients commonly have, besides pain, headaches, things like that, is their airway at the back of their throat can be very, very constricted. So many of these young patients have significant sleep apnea issues besides their jaw deformity. So this is a protocol that I actually developed back in 1990 to treat these specific kinds of pathologies where the jaw joints are destroyed. And so what we're going to do is we're going to reconstruct the mandible with an artificial joint. There's a lot of interference right now. There's a lot of interference. Can we stop the interference? Okay, thank you. So we're going to reconstruct the mandible and the TMJ joint with an artificial joint. And we're going to lengthen the ramus and shift the mandible forward with that prosthesis. So that's the first step here that we're going to do. And then in addition, we borrow some fatty tissue, usually from the abdomen, and we pack that around the prosthesis to prevent reactive bone and scar tissue from forming around the functional part of the prosthesis. We then do what's called a coronoidectomy. That's this little piece of bone here that we normally have to take off, or otherwise we can't get the lower jaw down and forward to where it needs to go. And then we do maxillary osteotomies, which is where we reposition the maxilla with a Lefort 1 osteotomy. And most of the time, we're going to lengthen it in the back vertically. And so we're doing what we call this counterclockwise rotation, where we're taking the jaws and we're just sort of coming way around like this, just rotating everything around in a counterclockwise direction. We also then, at the same operation, can do other procedures such as a genioplasty, such as you see here. We can do rhinoplasty, septoplasty, turbinectomies, whatever else may be necessary. And we do this all in one single surgical stage. So for that young lady that you just saw a few minutes ago, this is her treatment plan. We've brought the occlusal plane angle down to a normal 8 degrees. We brought the lower jaw, lengthened it vertically in the back and advanced it forward. Did a little genioplasty here. So her chin point right here is going to come forward a total of 28 millimeters. Again, all in one surgical procedure. We do all of our planning on the computer using a virtual surgical planning. And in the upper illustrations here is where the patient is in her original position. In the second set of illustrations here, we've repositioned the mandible. And you can see what we've done. We've brought the mandible down in the back, and we've shifted forward in the front, creating this significant open bite here. And so then the company that does the virtual surgical planning for us then makes us a bite splint to fit between the teeth that positions the mandible into its final position. And then we put the prostheses in here to hold that mandible in its new position. And then the next step is to move the maxilla down into its final position. Here you can see we brought it down in the back. It's come forward some here. And then we also did a genioplasty. So all that is planned out ahead of time as to specifically what we're going to do and how we are going to move the structures. And this is the kind of result that we can achieve for these young patients. Significant improvement in their profile. We can eliminate their pain, their headaches, significantly improve their airways, and eliminate their sleep apnea issues, and make them look relatively normal and function normal. And what a significant impact this has on these young patients psychologically. And importantly, achieve a good functional occlusal relationship that's very, very stable. So we've done a couple studies, and that was one of the purposes of the paper that I submitted to PAR. And the first study that we're going to look at here is where we looked at using this particular protocol of reconstructing the temporomandibular joints and advancing the mandible with that patient-fitted prosthesis and doing the orthognathic surgery, including repositioning the maxilla. We wanted to look at the stability. Is this a stable procedure or is it not? So we have 42 patients in this particular study, predominantly females, because this disease process occurs more commonly in females. The median age was 17.5 years. So you can see we're operating on fairly young patients. The mean follow-up for this study was almost 4 years, and all the patients had combined temporomandibular joint reconstruction, mandibular advancement, and the maxillary osteotomies. And then most all the patients, 86% of them, had a genioplasty done at the same operation. And this is the analysis that we used, a cephalometric analysis, which is a lateral X-ray of the patient's jaw structures. And we took 3 of these. We took one at T1, immediate pre-surgery, T2 was immediate post-surgery, and then T3 was the longest follow-up. Now, we used 20 cephalometric landmarks, and that's all these little red dots that you see in this area. So we can analyze the skeletal changes as well as the dental changes and also the airway changes. We also looked at a number of different angles that we use in analysis also to determine various deformities and to evaluate our outcomes and also to facilitate our treatment planning. So for surgical change, we looked at the T2 image, the immediate post-surgery cephalogram, and compared that to the T1, the immediate pre-surgery. That gave us the surgical changes we were obtained with the procedures. And then we looked at long-term stability, where we looked at the T3 and superimposed that on the T2 to determine the stability of this protocol long-term. So these are the changes that were made. I'll point out some of these. Point A is this point right here on the maxilla. It was advanced about almost 2 millimeters and had about a 0.5 millimeter post-surgical change, which mainly is just remodeling of that part of the bone. The upper incisor came forward about 4.5 millimeters. So that's this point right here was advanced forward about 4.5 millimeters with just a very minimal post-surgical change of about 0.2 millimeters. Now, the big indicators for stability are the next ones here. Point B, it advanced almost 16 millimeters. So this is point B right here. So it advanced forward 16 millimeters. And then the other big area of change is pogonion. That's the chin point right here. and it advanced almost 24 millimeters forward. That's almost an inch that the lower jaw was brought forward. The occlusal plane angle, which again is this line right here, decreased significantly by 17 degrees. Those are huge changes for this patient population. And the stability of this, point B had no relapse. Pagonion, the chin point, had just very minor changes, some of that just remodeling of the bone. Occlusal plane incredibly stable with only a 2/10 degree change. The other thing that we looked at was what happened to the oropharyngeal airway, because many of these patients are very constricted back there and they have sleep apnea. So for this study, the average amount of increase of the oropharyngeal airway was almost 6 millimeters, a statistically significant change. So this is just another typical patient. She's 14 years old when we did her surgery. The onset of her JIA was at the age of 6 years, just completely destroyed her TMJ joint. You can see the severe deformity that she was left with. Significant malocclusion. She only hits on her very back teeth here. The rest of her teeth are completely out of occlusion. And here's her cephalometric analysis. And look at the steepness of her occlusal plane here, 33 degrees. Remember, the normal is 8 degrees. The other thing that she has is severe constriction of her oropharyngeal airway, only about a millimeter airway. She has to really struggle to breathe. So we're dealing with multiple issues here, significant jaw deformity. This is what we plan to do for her. Again, we're going to reconstruct the mandible and the TMJ joints with the prosthesis. We're going to do this huge counterclockwise rotation. The mandible is going to come forward, including a genioplasty, a total of 38 millimeters, again, all in one surgical stage. The upper jaw is going to be advanced forward some. It's going to be moved up in the front and down in the back. So with that kind of movement, it allows us to get this kind of an outcome. This is about a 4-year follow-up on the right-hand side. And significant improvement in her airway, significant change in her psychosocial well-being. And importantly, able to achieve a very nice occlusal result, as you see over here. Very stable. The second or the second study that we did on this group of patients was they do have some significant pain issues, functional problems. And so this second study we did was to look at this same protocol and see the effect it has on reducing symptoms for this patient population. So in this particular study, we had 40 patients that met the inclusion criteria. That median age still is about 17 and a half years old. Follow-ups close to 4 years. And most all these patients, except for 2, had combined maxillary and mandibular TMJ reconstruction. And this is the primary variables that we looked at: TMJ pain, headaches, jaw function, diet, disability. And those factors were evaluated using the Likert scale of 0 to 10, where the lower number 0 means things are normal, no pain, good jaw function, no disability. And 10 is the worst, where it's worst pain imaginable. The jaws are frozen shut. They can only drink liquids, can take no solid foods at all, and are totally disabled. The other factor we looked at is post-surgical quality of life. And the patients were asked at the longest follow-up if their quality of life was improved, if it was the same, or if it was worse. The other thing we looked at was the incisal opening, how wide they could open their mouth pre-surgery compared to post-surgery. So this was the results of that study. Pre-surgery, the pain level was at a 4 for TMJ pain as well as headaches. And the post-surgery, these patients were essentially totally pain-free. Jaw function was sort of in the mid-range of difficulties with jaw function, normal jaw function at the end of longest follow-up. Diet was affected with the deformity and was totally normal at the longest follow-up. Likewise, disability, the abilities for the patients to carry on normal life activities was affected beforehand. Afterwards, none of the patients reported disability. The incisal opening was 36.5 millimeters beforehand and increased over 7 millimeters at the longest follow-up, with all within a normal range of opening. Quality of life, 38 of the patients, 95%, reported improvement in their quality of life. 2 patients stated that they remained the same, but no patients were worse off post-treatment. So the conclusions of this particular study was that this particular surgical protocol of using the TMJ concepts, total joint prostheses to reconstruct the TMJ joints, advance the mandible in conjunction with maxillary osteotomies, in this JIA patient population provided significant long-term improvement relative to TMJ pain, headaches, jaw function, diet, disability, incisal opening, and quality of life. This is an independent study, but I put this study in. It's not involving just JIA patients, but a whole group of different kind of TMJ pathologies treated with this total joint prosthesis system. And so this was a 20-year follow-up study. There were 56 patients that we had adequate records on for follow-up. The median follow-up was 21 years. So pretty good follow-up on this group of patients. Overall, the patients experienced a 7.7 millimeter increase in their incisal opening, a decrease in TMJ pain by 5 units, jaw function improved by 4.5 units, and diet improved by 4 units. 48 of the patients, or almost 86% of the patients, stated that they were improved in their quality of life afterwards. 6 patients remained the same, and 2 of the 56 patients felt that they were worse afterwards. Importantly, no devices were removed for material wear or failure. So these prostheses all hold up pretty well. And this is the final patient I'm going to show. She's a very special patient. She is the very first JIA patient that I treated back in 1991 with this particular surgical protocol. You can see her bony chin is way back here, sitting almost on her trachea. This is her cephalometric X-ray. You can see the severe retrusion of the lower jaw, the decreased airway, maxilla significantly malpositioned in what we planned for her. And what with her, we used a prosthesis. We lengthened the ramus 30 millimeters and advanced it forward with a genioplasty, a total of 42 millimeters, again, all done in one surgical stage. The incisors were moved upwards in the front, down, maxilla down in the back to recreate a relatively normal occlusal plane angle. And enabled us to end up with this. And so this is her on the right-hand side, 1 year post-surgery. See the improvement in her aesthetics, her profile, and her occlusion. Good incisal opening, but a very nice, occlusal outcome. Very stable, very predictable with this treatment protocol. Here she is at the age of 14, shortly before I did her surgery, and at the age of 17, where she graduated from high school. And on the far right-hand side, you can see a 24-year follow-up of this same patient. Showing good stability, totally pain-free, good jaw function, good stable outcome. And importantly, also a good stable occlusion. There's no other way to achieve these kind of outcomes without this protocol. This is the only protocol that can produce these kind of predictable outcomes. So what's the unknown about these prostheses? First of all, we don't know how long these prostheses will last. The longest follow-ups that I have right now are at 31 years, almost 32 years. And in that time, I've never had to replace one yet because of it wearing out. And I've placed over 1,800 of these patient custom-fitted total joint prostheses. And of course, our 20-year follow-ups that we have support the longevity of these devices. But again, we only, some of my patients now are only 31 years follow-up, but still have the prostheses. The outcome goals then for our patients with JIA and for anyone with a severe jaw deformity related to TMJ pathology, our outcome goals for using the TMJ concepts, total joint prostheses, and this combination with orthognathic surgery is to establish good function and aesthetics, provide predictable and stable outcomes, and eliminate pain and discomfort. And importantly, make patients happy with the results. And I think this is achievable for most of these patients, particularly those with the juvenile idiopathic arthritis condition. And I thank you very much. That completes my lecture.